Melissa,
Good.
can you hear me? Okay, good.
Okay.
Sorry, I'm using a loaner laptop, so it looks a little different than normal.
All right, Darlene, we're all set.
Okay, well, thank you. And I'm glad I wasn't late. So, first of all, I want to thank Melissa and I want to thank Marlene and also Amy for doing this safety forum. And not just for the safety forum, but even throughout this pandemic, we have been staying on top of high reliability responsibilities and focusing on safety. We've even offered quality forums on safety, which we've been recognized at a national level. So I'm happy that we're going to have the anticoagulation discussion this morning. I want to thank you all for joining. There's not many, but I know that this is a challenging time for many people. But I want you to think about what safety means to you personally. I want you to always be thinking and keeping safety in the back of your mind, because as you know, this is all about our veteran. This is all about supporting the culture of safety that we have. This is about committing to zero harm. And this is about learning and asking questions and then improving everything that we do. So thank you for joining the Safety Forum. Again, I can't say enough about Melissa and Amy and Marlene. This is a group of people that you have so much fun when you're doing these planning activities. And I think that's what I missed the most when I was involved, is the activities as well as the laughter that occurred while we were planning. But all of the work that has been done by these three individuals and more, there are so many more that are focusing on safety. It really has demonstrated we are leading the network in our providing safety to our facility and to our veterans. So thank you very much, and thank you for the opportunity to be on this call with you all today.
Thank you, Darlene.
You're welcome. I'll go off camera so you could go on.
Okay, Melissa, did you want to go through our agenda for today?
Sure, Amy, I'll go through our agenda. So we have an opening safety story, and then we have a teaching slide on reluctance to simplify, getting to the root causes, and then an overview of two anticoagulation RCAs and outcomes, and then an overview of anticoagulation clinic services and clinical pearls. And then at the end, we have HRO Jeopardy.
Okay, so I'm going to open up with a safety story. We were thinking back to a lot of the great items that came up during the pandemic and different types of projects that we worked on and different types of safety issues that came up. And taking a glance out of the COVID world, there's still plenty more for us to talk about. So I chose to take a different direction and focus on one that is not COVID related. This one relates into pharmacy auto substitutions. With VA, there's oftentimes contract changes for different drugs. So, one drug is auto switched for another one due to changes in contracts. And so with that, pharmacy participates in making sure that one drug gets transitioned to the next. But however, doing so, we do have humans that are participating in that process. And we do know that humans do create error. And so what we were finding is that there were some errors that were coming up, mainly and so with duplication of prescriptions, meaning that we would auto sub to the next drug that was on contract, which would be clinically equivalent, efficacy equivalent, and that sort of thing. However, what was happening is that some of the pharmacists were leaving the prescriptions that the patient was on also active. And so which case that could create a vulnerability in the patient receiving both therapies. So with that, we looked at the process, and a creation of a Power BI report was done, and that report actually has really gone leaps and bounds in helping us with this process, because what happens is the report will automatically generate an alert to certain assigned users of potential issues with the conversion. So the example being one, if we have 2 drugs that are duplications on file for the patient, it would give us an alert to that. And so with that, it really got us to several pillars in HRO, but one specifically that relates to this month is the reluctance to simplify and getting to the root cause. So really taking a look at the process, seeing what was going wrong, seeing what we could do to make it safer. And with that, by leaps and bounds, that process is certainly greatly much safer. And if there is any kind of an issue that could come up with these conversions, we are now alerted to them in the system. So I just wanted to share that safety story. Very proud of it. Very proud of folks coming forward and working together to decide what the best approach was to move forward. And it's definitely a great example of this month's theme of the month. Thanks, Melissa.
Okay, and now we have a little information on reluctance to simplify. Just gonna see. Marianne, are you on?
I am here, Melissa, yes. So our key message is reluctance to simplify, getting to the root causes of the problem rather than settling for a simple explanation. So our key points are by digging down to the root causes, we identify systemic issues that make us susceptible to mistakes. So we can continuously improve our process to minimize weakness. We count on our leaders and staff members to not accept the first or easiest answer as true, but we keep asking why until we identify the root cause. Identifying the root causes and learning from our mistakes requires trust. We encourage each other to report and respond to errors. In a just culture, errors are seen as learning opportunities that inform our improvements. As we move along our journey to high reliability and work to create a just culture, everyone's mindset shifts from who is to blame to asking what are the root causes of the challenge or problem.
Okay, thanks, Marianne. So now we're going to talk about our 2 RCAs that occurred.
Can I ask one question before you go on? So Melissa, go back to the slide before.
Yep.
I think that the last one, as we move along our journey to high reliability and work to create a just culture, right? Everyone's mindset shifts from asking who is to blame to asking what are the root causes of the challenges. Are we seeing that more now as we're really journeying, we're on our journey? Are people starting to say, I don't want to blame, I want to really find what the challenges are? And what examples could you give me that we're doing that?
Sure. So some of the examples that, both Amy and I think have seen and others is that the safety story is a great example of how we're looking at what are the root causes of the challenge. I think pharmacy does this very well with discussing, with looking at what systems we have, what's in place, what could we do better. I'm seeing that a lot in some of the different incidents that are being reported and the responses to those, such as, what can we do to improve this process? Really looking at the process versus looking at the person. There was a lot of great discussion during the CTT training that we held last week. Rob and I heard a lot of, good comments about, looking at what kind of challenges we are experiencing and not necessarily who is involved in that, who specifically.
Darlene, I think one of the other highlights is we do see staff self-reporting. So for us, it's a clear sign of a just culture that they feel comfortable to be able to speak up, that if they're making mistakes, they're not afraid to bring them to the forefront, and that they're working with us to determine where in the system we could make things safer. So I think that definitely speaks volumes to us being well on our way to a just culture throughout the facility.
Great. I really wanted to stress that, Amy and Melissa and Marlene, because I think the work that the three of you are doing, along with Rob Sklernick and the rest of the team in quality and in HRO, and now as we add in Marianne Jones as she learns, I think we're seeing a really good outcome based upon what we're trying to do. And as a facility director, this tells me this is just not a flavor of the month. This is something that has a lot of emphasis on, this is all about the veteran, and this is about committing to zero harm, and this is about that safety culture. And this tells me we're learning, and I'm really pleased. So thank you for allowing me to stop the line and ask a question.
And Darlene, it's Marlene. And like you said, we are seeing a lot of increases in incident reporting. We're seeing increases of, emails, phone calls, to leadership and to quality. And, that's not that, oh my goodness, more things are happening. It's that people aren't afraid to speak up and people aren't afraid to bring concerns to the table. And that's one of the huge keys to, HRO and to just culture, is identifying those issues or concerns that the frontline staff have and bringing them forward and not being concerned about what the repercussions may be if they bring up a concern.
Great comments, Marlene. Thank you.
And we do have a lot of great thoughts going on in the employee entrance right now. Melissa asked a great question this week, is what does safety mean to you? And so we're asking folks as they're going in the employee entrance to put that down on a sticky note and put it up on our Shamrock. And at the end of the week, we'll share that with folks. So whether you're in the building or not, you'll be able to see a lot of incredibly thoughtful comments on what safety means to folks. So I think that also speaks to the facility as a whole as well. We've got a lot of great comments on there and a lot of great things to think about. So we're really proud of watching that Shamrock fill this week as well.
Those were some great comments and a great question. We're going to, if everybody's ready, we'll move on to the next slides. And those are looking at two RCAs that occurred in our facility. The first is our medication aggregate, which was done on looking at anticoagulation in the outpatient area. So the problem identified was improper ordering of outpatient anticoagulation, and many veterans receive their medication from both from the VA pharmacy, but they're co-managed in the community, meaning they have a community provider. The contributing factors that we found were the consults are entered with missing information. So oftentimes pieces that the anticoagulation clinic needs, or that that they need to have in order to dispense that medication is not available. So for co-managed veterans, information may not be available in the chart when the consult is entered, so that information is not getting where it needs to go prior to that consult being entered. So the anticoagulation clinic does not have it. The actions identified were updating the DOAC atrial flutter, atrial fibrillation consult to include weight, creatinine clearance, serum creatinine, and age, and then to standardize a process for obtaining information prior to entering the consult so that it doesn't cause a delay in dispensing the medication. Does anyone have any questions about this one? Okay. The second is an individual RCA, a veteran with multiple comorbidities and an extensive cardiac history, including AFib, was admitted to the ICU with acute hypoxic respiratory failure and E. coli bacteremia. Rivaroxaban was held due to elevated INR, and a couple of days later, the veteran was transferred to the medical surgical unit with telemetry. A CT without contrast was ordered, and the patient was brought down to radiology. The veteran tolerated the CT until the end of the test, where the arms come down. When he came out of the machine, it appears that the veteran was in distress and became unresponsive. A rapid response was called an error at first, and he was confirmed to be DNR, DNI, and pronounced deceased. So the actions identified from that are that anticoagulation monitoring will be reviewed by providers on admission and a transfer. Monitoring, which Joe will get into in our second and our presentation part of this. The INR was being monitored, which is not the correct monitor for this medication. A cardiology consult should be considered for patients with complex cardiac history. Consistent processes will be used for obtaining and monitoring weight in high-risk patients. So those are our two RCAs. If there's no questions, we'll move on to Joe.
Hey guys, good morning everybody. So I want to start out by thanking Amy and Melissa for all their assistance in addressing the concerns that we identified here, and for the opportunity to speak with everyone today and really dive into some of these safety concerns related to the management of anticoagulation and how we can address the RCAs to improve outcomes. So I'll also clarify some common clinical misconceptions related to the management of anticoagulants. Just kind of hoping we'd get some more ER or inpatient providers. And then I'll provide a brief overview of the services provided by the anticoagulation clinic to our veterans. So here on the slide, we're going to look at some overarching issues that were identified during the aggregate review and during the RCA that was outlined. So there's been inappropriate management of the DOACs, which are the direct oral anticoagulants. So those are Eliquis, Rivaroxaban, which is Xarelto, Dabigatran. And both the inpatient and the emergency room providers are using a PT-INR to guide therapy. This has resulted in numerous inappropriate holdings or interruption of the anticoagulation therapy, which have resulted in negative patient outcomes, including the event which was discussed above. So inpatient providers are not, in addition to that, inpatient providers are not ordering INRs on warfarin patients, so they're not providing daily monitoring, or they're ordering them too late in the day. And we just like to get those results sooner than later, so we can provide recommendations to the teams prior to them rounding on the patients. Then we're seeing incorrect reversal, using vitamin K to reverse the DOACs. And then we're also, what Melissa mentioned earlier, we're seeing missing information on the outpatient consults, which are needed to initiate the DOAC therapy. And we've been in the process of updating and reviewing these things for months. We've been refining that consult, further and further, and we actually have another update that I think really streamlined it, is going to prevent a lot more errors. That's in the hopper and should be approved either today or tomorrow. So if we can move on to the next slide, please. We'll review the services that we provide on an inpatient basis. So the anticoagulation clinic provides monitoring of anticoagulation, which includes the warfarin, DOACs, and low molecular weight heparin, such as enoxaparin. So we provide these services for patients who are enrolled in the VA and are on VA anticoagulation therapy, as well as non-VA anticoagulation therapy. So if they come in on, therapy from a non-VA provider or from a nursing home, we still help manage. So we provide recommendations regarding therapy. We don't actively manage, and then we help complete consults to start new therapy. So for warfarin patients, we look at them every single day. That's why we ask for those INRs daily. We provide this service Monday through Friday. And providers are alerted to our recommendations, but they're ultimately responsible to implement the changes. Again, we can't order on an inpatient basis. We can just provide recommendations. The DOAC patients are reviewed upon admission, and then weekly or as indicated, driven by clinical factors, kidney function, things of that nature. Enoxaparin patients are reviewed, again, very similar to how the DOAC patients are. But we only review therapeutic dosing. So if anyone's on prophylactic dosing, either for heparin or for enoxaparin, that's not something we look at. Another issue we kind of identified was a delay in transitioning patients from parenteral to oral therapy, which sometimes delays discharge. So we try to provide education on that when we can. I provided in this slide how to enter that consult. And then if we could kind of move to the next slide. So we'll kind of talk about how anticoagulants should be approached by the inpatient teams. So once again, the inpatient teams need to order the labs and the medications. We provide recommendations. The PT-INR guides daily recommendations. Even if a patient's stable, we always recommend a daily INR because so many things can change on the inpatient setting, as we all know. We also recommend a CBC periodically or as needed for that particular patient. And then when we move over to the DOACs and enoxaparin, the low molecular weight heparins, we always recommend, a daily or as needed CBC and CMP to really guide the dosing of the therapy. And it really needs to be stressed that PT-INRs really should not have anything to do with DOAC therapies. The APPT and the PT values do not reflect the plasma concentrations of the DOACs. It's kind of a known fact, and it has been for at least 10 years, that some of the DOACs will cause elevated INRs, which are incidental. They're not, they should not guide therapy. In certain cases, this is quite rare, we may use that to identify a patient who's replete in vitamin K, but these types of things should be done with hem-onc assistance, and really we shouldn't be seeing this any longer, to be honest. So if we're seeing a high INR and there's a concern and the patient's on a DOAC, hematology should really be consulted, and their opinion should be obtained before vitamin K is given or therapy is held, for that matter. So we can move on to the next slide, please. We're going to talk about the appropriate way to reverse anticoagulants now. So it should be noted that the reversal pathways are readily available in VISTA. They're through the clinical pathways, so they're right there at everyone's fingertips. And then additionally, they're also on the SharePoint. I provided direct links via this presentation, so hopefully we can disseminate this somehow. But as you can really see, warfarin therapy, reversal is guided by a couple things, right? We follow the clinical pathway here, but the INR result should be the first thing we look at. Then we look at if there's active bleeding, because that'll stipulate if there's a need to reverse. And then the clinical need. Is there urgent surgery? Do we need to reverse immediately? Because that would kind of supersede any of these things. Can you move on to the next slide, please? And then the reversal of the DOACs, I just used Eliquis here as, just a kind of a cut and dry, because that's the one we see the most. It's really guided by active bleeding or hemorrhage. So if the patient's not bleeding, the half-life of this drug is such that, it gets out of the body pretty quick, and reversal is typically not needed unless it's a life-threatening condition or pretty severe active bleeding. Typically, a minor bleed or no bleed, we just hold the therapy. It's typically out of the system within 24 hours. The big thing to kind of point out here is vitamin K does nothing anywhere in this pathway. That's not how the drug works. And we really shouldn't be giving it. We have a new tool, which we've been using, that has allowed me to identify an appropriate use of vitamin K in the ER. And I had just a really quick brief in service for some of the ED providers. And I think it was just a lack of, or a disconnect in current guidelines that we were able to clarify and really mitigated any of these issues. I haven't seen any in a couple months, so that's kind of been taken care of, which is great. Now, if we move on to the next slide, I'm just going to quickly review the services we provide. So on an outpatient basis, we're a consult service for monitoring and initiating therapy. We can enroll these patients and we'll manage the veterans who are started even by non-VA providers. So as long as we have those records. So we keep warfarin patients in the clinic for the entirety of their therapy. And then the DOACs are actively managed for the first 3 to 6 months. And then if they're going to be on long-term therapy, we'll transition them to the primary care. Some exceptions of patients we may retain will be guys who are on short-term or limited therapy, maybe following a procedure, or maybe, if they're going to be on it for a clot for 6 months. And then if the guys have, borderline renal function, or if they have something like severe anemia, thrombocytopenia that they really need to keep a watch on, we'll retain them there in clinic just to keep a closer eye. But even when we put them back to primary care, we're still providing a population management service, and we're identifying these issues, on a daily basis, utilizing our DOAC dashboard and identifying the primary care providers. We're providing the management. Can we just move on to the next one? So for warfarin patients, therapies monitored, for unstable patients, a new start pretty closely. Then after that, we kind of stretch it out when we can. And we never really go further than 6 weeks. For outpatient monitoring of the DOACs and enoxaparin, we do a CMP and a CBC 30 days after we start therapy, then again in 3 months. And then if we can, we transition them back to primary care management, or we'll make the decision at that point to retain them in clinic based on the clinical picture I discussed above. So to kind of wrap up, these are some issues we identified. They're pretty cut and dry fixes that seem to just be a slight, something we need to bridge in the clinical knowledge of maybe some of the residents coming in that are just lacking, a small aspect of this. So we really want to make these slides available. I've discussed with Angela, we're going to maybe make a pamphlet or something and discuss with the chief resident how to disseminate this information when they start here at the VA, because this is some baseline knowledge that they should have, wherever they go. And we want to be sure that they are also, aware that we're here, they know the services we provide, and that they feel comfortable reaching out if they have any questions. That's what I got.
Thank you so much, Joe, for presenting. We appreciate it. And Sean, I believe we'll make sure that the slides are available so that everyone can review them after this.
Hi, Melissa, it's Sean. Yes, I can send the slides out with the postmaster, but also I've been recording the whole thing. So what I'll do is make a link, and then when we're done, I will submit it, or I'll send it out as a postmaster, everybody.
Thank you. So that's our the first part of our presentation for the safety forum. Does anyone have any questions?
Isaac's in the library.
Isaac is in the library. He's getting down to business. All right, good. So Isaac and Anthony, would you introduce our teams to everyone and let everybody know who our contestants are? And then Kit is going to share his screen, or somebody's going to share their screen to show Jeopardy, and then we are going to get going.
Hi. Yeah, so Kit will do the Jeopardy screening and taking scores in the background. And Isaac and myself will try to make this as fun as possible. I know some of you know us by, from the building. I don't want you to think that you can get any special favors or preference. Marlene, thank you for the lunch today. I took a quick glance at it. It looks good, smells delicious. but I digress.
Not a problem for anything for you too.
Yeah.
Check in the mail,
all right.
Anthony. Check in the mail.
Sean, keep the banter down to a minimum. You want to keep this fair, firm, and impartial.
I have theme music for each correct answer that we get, just so you know. It's all ready.
Hey, Rob, I appreciate the rubles that you sent me. That's a great long-term investment. Thank you.
Absolutely.
All right, so we have team 1, the valedictorians, Sean and Joe. You know, Sean gets credit for a lot of things, and deservingly so, but for his modesty, doesn't get enough credit. Team number 2, you know, gems of quality. Marlene, thanks again for lunch, and Alicia. Yeah. And then team number 3, stolen base, Eric and Rob. And Rob, curiously, your last name looks familiar. I don't know where, but you know. But if you know my boss, you may, you know, they're not working hard today.
Hey, Rob, why is your team name Stolen Base?
Because we're safe.
Nice.
Brilliant.
Nice. Yep.
All right, so we will give team 1 the first go. So Sean and Joe, you guys pick your category and amount.
We didn't even think about this, Joe.
Yeah, we did not get a strategy. How about HRO principles for 300?
Think is not this strong point.
Oh, well, how about for 100? I think Kit went with the 100. Oh, no, it's the 300. And the answer is...
Going to give them an unfair advantage here. You're giving them all the questions here.
No,
All
we
right,
don't, it doesn't say, it doesn't show the answer.
I'm sorry, was
Alright.
it 300 or 100?
300.
Okay, 300.
Team 2.
Whatever you want, kid. It doesn't matter. We'll get it right. Don't worry about it.
All right.
Like that confidence.
Yeah. So the answer is, it is something you bounce back from.
Team 2.
Team 2.
Commitment to resilience.
No. Close, but no.
Something you found.
And 3, 2, 1.
Team 1. Team
Time's
1.
up.
Team 1. So
Team
our
one.
answer to something we bounce back from is
Something failure.
You guys know this. You guys know this.
barriers to
And 3, 2, 1. Time's up, Sean. You know,
Sean.
I have my lunch to get to. We gotta keep this going.
I'll let
All
you
right.
guys know what wasn't the answer. It wasn't a hangover. Safe to say.
Should I?
And-
Let's
All
see
right.
the answer.
And the answer is, Kit, what is a mistake?
Classic.
I
Or
thought you
that's the
wanted the,
question.
I thought you wanted the heading of the principal.
Same.
Marlene,
getting
you don't
too
get-
academic.
Yeah.
my
you don't
mistake
get
was my
points for
picking my
technicality.
partner. All
All right, team 1, the board is still yours. Where are we going?
right, we're
Wait, so
going for HR principles for 500, Alex.
Should I subtract points from team 2 and team 1?
I don't think you should.
Team 3.
Team 3.
Stolen base. Here we go.
What is deference to expertise?
That is correct.
That sounds like a good answer, Rob.
That did seem like a really good answer.
And this has been a great investment for me. Jeez. Great job, Team 3.
Team 3, the board is yours.
Rob's gonna run the board. I can just see now.
Yeah.
Team 3, 30,000 points.
What HRO values for 100?
The answer is
The
our
patient. Oh,
decision
team
tree.
1, team 1, team 1.
Team 1.
The veteran.
There you go.
Wait, I forgot. Am I supposed to subtract points if they didn't answer the correct answer?
Yes, because they
Absolutely.
didn't say who.
Wait,
Who or what? What is or who?
You didn't hear the mic cut out. We did say who's a veteran.
Wait, like, I mean, the first question, should I subtract 300 or should I just let it go?
Oh, we'll just let it go.
Oh, let it
Yeah.
go.
Yeah, that was a
Okay.
warm-up round. That was like practice, spring training.
They only get one mulligan.
And for the HRO principle 100, that wasn't answered yet. I just clicked it by mistake.
Okay.
Okay, sorry. Go ahead.
That's kind of what happens in quality. So no, we're used to it.
Your
Marlene's gonna
lunch
kill
will
me.
not be delivered.
All right,
So we get to
team
pick again,
one.
right? Why don't we
Yes,
do HRO principles for 100 just to make it easy for Kit?
Yes.
Wow.
Oh, you don't have to.
Eric, why are you always at the front of the building? You're never at the trailers.
Have you?
It's a
have
good
you
question,
seen-
huh?
Wait, did you guys pick already?
Yeah, well,
yeah.
we can do HR principles for 100, Kit.
Okay.
Okay.
And the answer is focus on catching.
You know these
Three.
guys.
Team two,
Team
Team
two.
two?
sensitivity to operations.
Oh.
Oh no, that answer is too complicated, so I'm gonna say no.
Team 1,
Team one.
focus on catching,
What is?
what is, um,
A mistake.
what is the answer? Can you
What
tell
is
us
a
what the
mistake?
answer is? Focus on what is mistakes? Final answer.
No. Close. Nice try.
I don't know if I like the way you said that.
Wasn't sincere.
I get no pleasure out of it. Well, maybe a little. All right. Time's up. Kit.
Okay.
What is an
Oh.
error?
That's the same thing.
I mean,
No.
I think we
Can we
get
talk
points.
to the
for that.
panel?
Yes.
the devil's in the details,
Talk to
people.
Directors here.
Devil's in the
Details. Details.
I'm phoning a friend. If Kirsten says that mistake and error are the same, I'm gonna ask for 100 points.
Oh, Kirsten, would you take that? You talked to Marlene the other day, so she said, "Yep, she would give mistake. Yep,
Okay.
There you go.
I will
do that."
at the point.
Hope
Okay.
200 for us. We're catching up.
All
We're in
right.
second place.
All right, back to team one.
Do we want to go for like a big money?
Yeah.
Let's do, should we do patient safety glossary?
Yes.
All right. Patient safety glossary for 500, Alex.
Whoa,
500.
playing with the government's money.
Type of it first.
Team two,
Team
Team
two.
two.
what is Sentinel event?
That's not fair. That's
do you
like
know that?
Marlene's, like Marlene's job.
Yeah, Sean, don't give up so easily.
That's a great
Still early.
answer.
And I could be wrong. I've been wrong already.
I think you're right. Let me double check my answer here. Yeah, we'll give it. Hit the answer there, kid.
Great answer, Marlene.
Yeah.
But Sean,
I'm
HRO
for
is everybody's job, so.
Yeah,
Thank you, Marianne.
take that.
Marlene, we threw you a softball.
All
there.
right.
Yeah, we were setting you up. We didn't want you
Team-
to.
Yeah, team two, the board is yours.
Trivia for 300.
Hmm.
Ooh.
Team 1,
Team one.
2013.
Incorrect, sir.
I think that's when you start your VA career.
Yeah.
Eric.
That would have been
Yeah.
2010.
Eric, yeah. You're only off by 11 years, Eric. You're close. You're very close.
That was Joe. That wasn't Eric.
Oh.
Oh.
Hey.
Use that all the time.
And you guys don't look alike. I don't know why we missed that.
Just take away 11 years from Eric's answer.
What? Joe.
What's the answer?
All right,
You have a
what's the
calculator?
answer?
2002.
Uh,
That's a good year.
Still us?
yep.
HRO pillars for 300.
They're trying to get some money. Blank are vocal, visible champions in TPI who foster a deep improvement culture.
Team 1.
Team
Who are
one.
who are the systems redesign coordinators?
No. I like it though.
That was
Ooh,
Rob's
Jazz.
answer. He told me that I had to say that.
Team
So
two.
we shouldn't lose points.
Team 2.
Leaders.
Correct.
That's a better
Leaders it is.
Hey, Marlene and Lisa making a little run.
Yeah.
Girls rule, I'm just saying.
All right, Team 2, the board is yours.
See what kind of gems you guys can drop on us.
Let's do patient safety glossary for 200.
The name of the medication error reporting system that we use at the VA.
Jeez. I feel like this is a trick question.
If you don't know the answer, Marlene, we don't need a long story. Just say you don't know. don't blame it on the question. Kit, this question's very straight and direct. Don't let Marlene.
Anthony said we don't need an ROC.
3, 2,
We don't have.
1.
Different.
Time's up.
I was gonna say that.
You
I
guys
thought it was
knew
a
that.
trick question.
You guys knew that. Trust yourselves.
That's
Trust
so
your
bad,
perception.
Marlene.
I'm
Well, I thought
disappointed in you,
we
Marlene.
I thought it was like in pharmacy, like if there was a different one.
Marlene, it's like taking the NCLEX. You always
I
go to
know.
first.
The problem is the NCLEX, there's always 2 right answers. That's the problem.
Yeah. Marlene, now I'm starting to think that you didn't look at the question and answer that I emailed you earlier.
Oh, yeah, I must have missed that one. I'm sorry.
Hmm.
Let's
She's like, I don't need.
let's do
Marlene's like, I
400.
don't need the answer key.
Right. Need no stinking help. Patient safety glossary 400. I'll stop thinking someone.
Method used to identify trends and system issues by analyzing groupings of similar events.
No,
I think I
oh
got
my
it.
gosh.
Okay.
Rob, I'm looking at you here.
Team 1.
I
Team
know
one.
one.
Aggregate root cause analysis, Alex.
Correct.
Nice. Well done.
Marlene.
I was blanking. I'm thinking too much. I have to get out of my head.
I love
And
doing
now-
those, so that's how I knew that answer.
And now we know why they're not NPs.
All
Wow.
right, team 1. The board's yours.
I think we need to go in the 400 range.
You got one. Do you want to do HR principles? HRO principles for 400, Kit.
Uh-oh.
Kit, can we call you Alex?
Of course.
Team 2.
Rather than settling for
two.
simple explanations, we should get to the
Team 3.
Not
Team 2
two
first. Team 2 first.
What is the root cause?
Correct.
Anthony, you're gonna have a good lunch. Jesus. Yeah.
Oh, Kit, before we continue, you by any chance have the scores at the moment? Give
Yeah.
people- What's team 1?
Yeah, so I didn't subtract any score. I just add the scores at
That's
the
fair.
after they were right.
Yeah.
Team 1, the valedictorian is 600. Gems of quality is, hold on, 700. Wait, 700 plus 500, 1200. Stolen base 500.
All right.
So team 2 has how many points?
1200.
1200.
Jeez.
Nice.
And team 3?
Team 3 is 500.
All right. Let's go.
Oh.
To our
Man,
phone
Anthony-
number, you need them.
Auntie's probably gonna have prime rib this afternoon. Jeez, man.
We are, I don't care.
All right, next question, all right?
I think team two has
Let's
them.
do HRO values for 500.
Blank has the duty to listen and respond to the concerns staff members raise.
Team 3.
Team 3,
Team 3, stolen base.
What is a patient advocate?
incorrect.
Oh,
But you said it with such confidence, Rob. I would have given it to you, but Isaac is a
Confidently
stickler for
incorrect.
rules.
Team 2,
Team 2,
everyone?
incorrect.
Team 1,
Okay.
Team 1,
what is a supervisor?
we'll give you credit. Who's the leader? Supervisor, leader, well,
Okay.
you know.
Was that
Teams.
team one?
Team 1.
Team
Okay,
1.
That was for 500 points.
Yes.
They're mounting a combat, what, 1100 now?
Team 1, where we're going?
HRO. Let's do. Can we do HRO pillars for 500?
Hmm. Safety and reliability are reflected in leadership's
Team two.
vision, decisions, and actions.
Team 2,
Culture of safety.
Didn't form the question as an answer. Or an answer is a
Oh.
question.
What is culture of safety?
incorrect.
Mm-mm.
Well, it might be a technicality. We'll come back
Oh,
to it. Anyone
What
else
is
have-
What is leadership? Team 1.
Team 1,
What is leadership commitment?
correct.
Yes.
Oh,
You were on
jeez.
fire, sir.
Gonna read the whole.
500.
All right, Team 1.
He
Where'd
must
we
be
go?
messaging Kirsten.
Trivia for 500.
Kirsten didn't answer that. What trivia for 500?
Oh, sorry, I didn't. Sorry, I zoomed out. What was that?
Sorry, trivia for 500, Kit.
Sorry about that.
Ooh,
Oh, I know
Team
this.
two.
Team 3,
Team 3,
861,000.
square footage of the Stratton VA Medical
Oh
Center.
We have.
correct.
What is?
You should know that. You walk around it enough. Jeez.
And how
Great
would you
answer,
know
though.
that, Eric? I'm just saying.
TLC inspection. It was listed in our briefing for.
Nice.
And we just put it in our joint commission application, so I just saw it.
Oh, man.
Where do we go next?
Team 3 trivia for 400.
Ooh. In what year
Team
did the
two.
Stratton VA Medical Center start the HRO
Team
journey?
2,
Team 2, 2018.
correct.
Final answer?
Don't forget what is.
What is? I get so excited,
Yeah,
Melissa.
no,
I can't
no
help
points
it.
for that one.
Well, technically in the first round, you can get away with it. Second round is where you, in Double Jeopardy, you have to include it as a question.
Oh, jeez. Okay.
Yeah. In Jeopardy round, you can get away without the question. Oh,
Strategize, guys.
all right, Team 2,
HRO pillars for 400.
They're taking all the big money. Across the organization, teams use effective
Team
tools
two.
for continuous learning and improvement.
Team
Team
2,
two.
Team 2,
Continuous process improvement.
What is?
correct.
What is continuous process improvement? I would fail at Jeopardy. if I get kicked out.
Wait, was that correct? I didn't catch that.
What is continuous process improvement?
Oh, okay.
They're taking all the big money.
Yeah. You know, you could have saved us time if you just said CPI, but it's okay.
I wanted to make sure that it was counted if I didn't say the whole thing.
It's tax season and they're taking all the big money. Jeez. Man.
Kit, what's the score?
Oh, hold on a second. So for valedictorian, it is 1600. Gems of quality, it is. Sorry, I was going to use Hold on. Valedictorian is 2,000. Stolen base is 1,000.
I like the 160 better, Isaac.
I keep doing. I keep.
All right,
This
team
in
two.
digits.
All right, go ahead.
HRO values for 400.
Blank has the duty
Team
to
one.
speak up.
Team 3.
Team
Three.
one.
Quick on the draw.
What is everyone?
Correct.
Ding
That was
ding.
Team 1, right?
Team 1. Yep.
Yeah.
Oh, my back hurts. I think it's
Altitude.
you all this time.
I've been helping Emily with all the right answers.
Maybe you should
Sean,
put
I
an
have-
economics eval in.
Sean, you can stop by on 3A. Price prosthetics. Get a back support. From Kim Nilsson on her team. And since you're winning, no consult needed.
All right, team one.
Oh, team. Let's do HR values for 300.
To create an environment where it is safe for employees to make mistakes.
Team two,
Team two.
culture. What is culture of safety?
Oh, Marlene.
I'm getting there. You can teach me.
Good guess,
Um,
Marlene.
Yeah. Yeah, we'll say it's right. Yeah,
I
You'll
literally
say it's
said
right.
that.
you know.
Marlene,
Thanks
I
for
posted.
changing. Yeah, Kit, thanks for changing the answer so quickly to match her response. That's good. Kind of you. Team two.
All right. Finish up that one.
Team 2.
Patient safety glossary for 300.
300, right?
Mhm. Yes.
Okay.
Method used. Identify system vulnerabilities from
Team
a
two,
close call.
Team two.
what is a root cause analysis or RCA?
Ooh.
Correct.
Textbook.
Yeah.
I want to make sure I had it full. I don't want to disappoint Anthony, so.
No, we took away the abbreviation because you didn't do it the last time. So, that was it. Team two.
Finish up.
Patient
Yeah,
safety
me too.
glossary for 100.
Team 1.
Team one.
What is a close call?
Correct.
Great. Jeez. These guys must. They must think of play.
Trivia
Play
200.
Belichick.
What was that, team one?
Trivia 200.
This robot is frequently seen in
Team
the hospital.
two.
Team
Against
one.
the force.
Team two.
Team
Team two.
What is tug?
Or
Actually,
Sherlock.
it's who is Tug, right? Is he a person
Yeah,
or
it's-
an
Well,
object?
it's not really a person, so I guess that's to be.
Hot, see?
In today's environment, we must be
All right.
AI have feelings as
I
well.
thought we weren't using acronyms. I thought you had to spell out what tug is, but that's all
We
right.
get,
I'll let them.
we get extra credit if we know their
Search
name.
of it.
I think we should.
I
Yes,
think
Marley,
we should-
what is the only tug that is currently working right now?
Sherlock.
No, of course
No.
not. No, his name is Holmes and you just hurt his feelings.
I'm sorry, Holmes. I'll come give you extra, I don't
Yeah.
know, electricity later. I don't know.
Give him a little juice.
I have to jump off for EOC meeting here. I
Wow.
gotta switch over.
Yeah, well,
Should we go?
It's
Can we
not-
go to Final Jeopardy?
all
Eric,
right,
you're
let's
so
go to Final
important.
Jeopardy.
Oh, wait, we need the scores first, so we
Yeah.
know we
All
have
right,
to wait.
So,
Oh, yes.
We're gonna
Yeah,
know, though.
so-
You don't know.
on a piece of
Yeah, we have to
paper,
write down our answers.
just write down how much your wager is. Oh, Kit, can you give what the total
Yeah, we need
score is
totals.
right now?
Oh, right, you're right. Oh,
Little money.
500. 21. Team 1 is 2,100. Team 2. I'm sorry, I was going to use Excel, but I don't know how to. Yeah, I couldn't share two things at the same time.
We trust you, kid.
Hold on.
Can you make it quick? Because Eric has his driver waiting on him for his next meeting.
Team 2 is 2,800. Team 3 is 1,000.
Oh,
There we
what was
go.
that for? Eric didn't hear you. What was the score for team 3?
Team 3 is 1,000. Team 2 is 2,800. Team 1 is 2,100.
All right, it's anyone's game. Please make your wager for Final Jeopardy, and we'll show the answer in a minute. Don't show us your number, Eric. Not yet.
Look, Eric.
All right, everyone's written down their wager.
Yes.
Rob,
All right.
I just messaged you
All right.
the last answers.
Yeah. Can the 3 teams on team? Actually, you can just write down your answer. Kid, let's see the final answer, please.
Oh, wait, sorry. That's the scoreboard. Oh, good to find it. There we go.
All right. Who is the all-knowing patient safety manager?
All right, Isaac, do the countdown. We'll give them 15 seconds.
All right.
Do we have to write it down or are we all just gonna say it?
Oh, write it down,
Oh, okay.
and then you can
All right.
say it just in case. Just in
Well,
case
say it. I
the
thought
boss
we had to
didn't
hold
want
it
us to, submit anything. I don't want.
And go. Rob, I just messaged you the last final answer. The cat is in the bag. Oh, my mic is on? Jeez.
All right, and 5, 4, 3, 2, 1. All right, we'll start off with team 3. Rob, what's your answer, Rob? Oh,
I
you're
got
on mute.
That's gonna be Dan. Who is Dan Brzezinski?
You said, what's the first name?
Uh,
I think he was saying Dan Gusevich.
Oh, that is
yeah,
incorrect.
who is Dan Gusevich?
That is incorrect, Rob. How much did you wager?
We wagered $999.
Oh, that drops you down
smart.
to a good dollar. All right, so we're gonna go to team 1. What is your answer?
We have Melissa Kerwinski for
That is
$2,100.
for 2,100. That is correct. All right, I will take you to 4,200. Team 2.
We have Melissa Krywinski for 2,800.
Oh, and I will take you to 56. And we have a winner. Team 2.
I would like to thank the Academy.
Oh.
Oh, and as a thank you, we're gonna reach out to your supervisor, and you guys can stay late tonight and play a little catch up.
Thanks.
I gotta go to environmental care.
Thanks, everybody.
I gotta go to another meeting. Thanks,
Joe.
guys.
All right, thank you.
Thank you. Bye.